Perceive, process, perform. Do you need inspiration for your practice? Or do you simply need to practice inspiration? With this series, we aim to do both. Give us 15 minutes and we'll give you practice inspiration. In this presentation, Dr. Hooman Zarrinkelk breaks down how to restore complex patients simply. He has a patient-centered approach to treatment that helps many people who have declined more complicated treatment plans in the past. He has a wonderful way of reconciling what we want to do clinically with what patients want for themselves.
My name is Hooman Zarrinkelk, and I send you greetings from a small coastal town in California, just north of Los Angeles. And I'm a simple oral surgeon who's been fortunate enough to be able to dedicate a big portion of his practice to complex dental implant treatment modalities. And by that, I mean that a majority of the patients that are referred to my practice nowadays are coming to me with severe atrophy of their jaws, where they don't lend themselves to the traditional approaches to dental implant restorations, or they come to me with mutilated dentitions or terminal dentitions, or they come to me as an end-of-line treatment or retreatment of other dental implant restorations that they've had where they have to be redone. But what I come to you today is really hopefully try to help you expand the treatment plans that you're able to, or treatment options that you're able to offer to your patients. And my hope is that I will be able to help you help more patients. Because that's the essence of what we want to do, is we want to help more patients. But what we have to realize, in order to help more patients, we have to reconcile a few factors that are involved in our treatments. And the most important one to me, and the most obstacle in treatment of our patients, is really what we as clinicians want to get out of treatment. And by that, what I mean is that as surgeons, we want to place the most number of straight, perfectly aligned implants that we can get in the most amount of bone that we can grow with fancy and expensive techniques, and to put them in the nicest tissue contours that we can provide, to create beautiful x-rays, beautiful radiographs, and sexy photographs that we can show our colleagues and look at ourselves and be proud of what we've done. But we have to be able to reconcile that factor with what the patients want. And in my experience, what the patients want is really one thing. These patients that I see in my practice only want one thing, and that is they want good-looking teeth. That's all they want. It's a secondary thing if they function well, but they really come to me because they want good-looking teeth. They also want it to not hurt. They also want it to not cost a lot. So we have to reconcile these factors along with what biology or what Mother Nature allows us to do and what the marketplace allows us to do. So we have to be able to put these things together, and very often when we put these things together, we have a mess. We have a mess that we have to reconcile. But when we do reconcile these factors that are involved in the treatment of our patients, very often we end up with beautiful smiles. These are all just a handful of the patients that I've been treating in my practice who decline other treatment options because the other centers that they visited did not reconcile all those factors that were involved. They were offered treatments that were complex, that were painful, that were expensive, but did not meet the patient's requirements. So you may ask yourself, why do I want to consider these new thoughts? Why do I want to consider these new treatment options? And the answer to that is very simple. It's simplicity. The simplicity allows more patients to be treated. You're able to help more patients. So sticking with that simplicity theme, as I've told you, I'm a simple surgeon. And nowadays, when I see our patients, when I see the patients that are referred to me, is I don't look at them at the factors that we talked about, or the factors that we talked about previously. I have a patient-centered approach to treatment, in that I look at these patients and my promise or my goal to them is that you're going to get 12 teeth, You're never going to have to wear dentures, and you're never ever going to have a graft. But what might really promising Kim on this, as this radiograph or this photograph you can see, is I'm going to offer Kim, with that dental situation, with that oral handicap, to look like this. And this is Kim, 2 to 3 days after both arches were treated. And when you look at this patient, I don't want you to look at that pretty smile. I want you to look at her eyes, because that's where you see this patient being transformed. Now, this is again a patient who was offered very complicated treatments, and she declined it. But we were able to produce a very happy patient. So they've asked me to condense my 2 to 3 day program into 15 minutes. And if I was going to do that, what you would have to consider is my 3 key factors. And the 3 key factors that I have that you need to consider, especially as a surgeon, is what I call the 3 S's. And those are stability, space, and spread. So what do we mean by that? And you may notice that one very important prominent factor is left off of this slide. And what would that be? And that would be the number of implants. Because in my book and my thought process nowadays, the number of implants is irrelevant, as long as we have 4 implants per jaw that meet these requirements. So whether it's 6 or 4 or 8, it doesn't matter. They have to meet these requirements that I have when I treat patients. So let's start talking about that. What do I mean by stability? Is that I mean that I need to have minimum of 4 implants that are very, very stable in bone. And what that means is you can take an ISQ value, or you can take a simpler approach, use the torque value in your torque wrench to decide whether that implant is stable or not. And I use a 35 Newton torque value as a minimum requirement for immediate load. Then you have to have space. What we've learned to successfully treat these patients with a successful prosthetic appliance is that we have a lot of space. We don't want to have fractures and problems with the prosthetic, so that you need a lot of space, so consider that. And finally, spread. We know that AP spread is the most important factor in counteracting the deleterious effects of forces that are placed on occlusion. So these are, when we look at implant stability or fixture stability, these are the factors that we have control over to get stable implants. And the number one is implant design. We want to use implant designs that are designed, or implants that are designed for use in compromised bone situation. Now this is the Nobel Speedy implant or the Nobel Active, and both of these implants are designed to be used in cases of compromised bone. Next thing we have is we want you to start thinking about these implants not as dental implants, but skeletal anchorage devices for our prosthesis. So what we're going to do is we're going to make sure that the apex of our implants are in very dense bone. And in the case of the mandible, that may be the inferior border mandible, or in the case of the maxilla, it may be the nasal floor, it may be the sinus floor, but we want that implant to engage the nasal floor, or very dense bone. And the third factor that we have at our disposal to assure stability of the implant is what I call implant osteotomy design. Now traditionally, when we were taught how to drill an osteotomy for an implant, we were taught to drill a perfect cylinder or a perfect tunnel with the same diameter the entire length of that cylinder. Well, in these cases where you're dealing with very compromised bone, I want you to start thinking about the osteotomy as a perfect funnel with an F, where the apex of the implant, or the apex of the osteotomy, is as narrow as possible, and you gradually widen that osteotomy to the coronal aspect or to the crestal aspect of the osteotomy, just wide enough to allow for insertion of the implant. And this short video, I think, represents this situation very nicely, where you can see that I start the osteotomy with a 2 millimeter narrow drill, and I drill it and engage the nasal floor. That's a 15 millimeter. But then the next diameter drill, which is a 2.8 millimeter drill, is only inserted to half the distance. So now you have the 15 millimeter osteotomy that's only 2 millimeters on the apical portion, and then you have 2.8 millimeters on the mid portion, and then it's only widened at the crest to 3 millimeters, just enough to allow for the tip of the implant to catch the bone, engage the bone, and then drive itself in. This will allow very stable implants and very soft bone. So this is the idea of designing your osteotomy to counteract the soft bone that may you encounter. The next S that you have to consider is as we talked about, is the matter of space. And what we're talking about is the vertical space needed for the abutments, the framework, the acrylic involved, and the teeth that the prosthodontist or the restorative colleague of yours will have to place on your implant. And what we know from them is that they require at least 14 to 16 millimeters of space per arch. That means 28 to 30 millimeters of space between the platform of your implants. That is a lot of space, but it's an absolute prosthetic requirement, and it's an absolute surgical requirement. That is not something that you can have your prosthodontist friend figure out after your implants are placed. You as the surgeon have to create that space for them. So let's look at a representative case. Let's call this Vincent, who presents to you like such. You can clearly see that there's not enough space to do anything, let alone put implants in. So this space has to be created surgically. Some of it can be done with opening of the bite, but most of it has to be created surgically. And that amount has to be figured out by your prosthodontist, by your restorative dentist. And it has to be communicated to you somehow. And that could be in any form, but at least a surgical guide or a bone reduction guide has to be created to allow the surgeon place it in the patient's mouth and determine how much space or how much bone I have to remove to give the restorative dentist that space that he needs. So if we look at Vincent's case, you can see that enough bone is reduced in the maxilla, enough alveolectomy is done to the point where you see only the apices of the sockets by the time I'm done. And when you're in the mandible, that's 16 millimeters of reduction. So when you see on the slide or the photographs on the left-hand side, you don't even see the apices of the sockets anymore. So as a surgeon, you have to be emotionally and technically capable of performing this. And that is very difficult for some surgeons. But if you cannot do that, then this is not a treatment that you should engage in. Once the bone reduction is done, then the implants are placed, and this is a traditional all-on-4 approach, and what I call prosthetically driven but anatomically guided placement of the implants, meaning that our implants are placed to bypass our vital structures like sinuses and nerves and to accommodate the anatomic structures that are, or the anatomy of the patient at reasonable angles, and then the divergence is corrected, or the angulation of the implants is corrected by these nice multi-unit abutments that are available to us that can create our angles so that our implants, our emergence profile is parallel to each other. And this is Vincent's case completed, and is successfully treated again. Our final factor, or the final S we have to worry about, is the spread, or the AP spread. And if you really want to understand AP spread or really want to address it, you have to read the works of Dr. Skalog, you have to read the works of Bo Rangert or Brunsky's work. And what I have done is I've summarized it for you in this statement, that the vertical and horizontal loads that are affected by the implants are most affected by the AP spread of the implants. What does that mean? That means that the deleterious effects that the forces on implants have is counteracted by enlarging or lengthening your AP spread, or widening of the implant placement. And we also know from Dr. Goodacre's work that shortening that cantilever by increasing the AP spread is the most important factor in failure of our prostheses. So when we look at our representative case like this, where we have bone in the anterior maxilla, we know that we can get implants in the anterior, but we're going to have difficulty getting a wide AP spread because of these large sinuses this patient has. So some of you look at that case and you may see something like this, where we have a patient that has undergone bone grafting, 6 or 8 implants are placed per arch, and she has a very successful, very beautiful restoration. But some of us have undergone a paradigm shift, and when we look at the same patient, we see this situation. We see this situation where 4 implants are placed, and they are angled to bypass our vital structures such as sinuses and nerves, and still the patient ends up with a nice result. And the difference is that the patient never had to wear a denture, did not have to get a second mortgage on her house to finance this. Some of us will go even one step further. In our extreme cases, we still follow the same principles. We still follow the same factors we talked about, such as the spread. Instead of getting our posterior support from a bone-grafted site or bone-grafted sinuses, we resort to zygomatic implants. And zygomatic implants are nothing new. They were developed many years ago by Dr. Brannemark to treat patients with oncological defect. And we know from his work on those oncologic patients that these are implants that are very successful, very predictable, and very easy for patients to maintain. So if we look at one of our patients where this was completed on, we see that the zygomatic implant has the same platform as a regular traditional implant, but it traverses the sinus, it engages the zygomatic bone. And that is the bone essentially where the prominence of your cheek would be. So this is a patient that you can see an all-on-4 procedure is done. We still use 4 implants, except that the posterior support is achieved from a zygomatic implant. Now what about a case like this? This is where thinking outside the box comes in. This is a patient who doesn't really have support even in the anterior maxilla. It doesn't matter. We still follow the same principles of stability, spread, and space. The only difference is that in a case like this, we get our spread with placement of 4 zygomatic implants. The net result is the same. The patient has 4 implants, they're zygomatic implants, but she still has the spread required for a good result. And this is our final patient, where you can see that she has a very nice result. She's happy. She never had to have a bone graft, and she never had to wear a denture again. So what I want to say to you was with thinking outside the box, sometimes you can do great things in your patients' lives. Thank you for your time.